for the hernia session in the Indo-UK-SURGICON, which was uh, revisited in this week. And many of you had the opportunity to watch it. I hope that everyone learned from this session, which was conducted by the IAGES with collaboration with the Royal College of Surgeons of Edinburgh. I have jotted down points that I learned, and I hope that these points are also useful to you uh, from the event, the 6-7 hour event of Indo-UK-SURGICON hernia session. The first thing that I would like to submit is that hernia surgery is rapidly evolving. And I think it's just a statement that everybody knows. There is so much of change that is happening that many of the senior surgeons are forced to ask during the session itself, are we dumping what we have learned in the past? And I would like to answer that by saying not at all. We do not dump anything that we have learned in the past. We always build ourselves by climbing on the shoulders of our senior people who have taught us, and then we try to look beyond that. And in fact, in hernia, I would say that we are only revisiting things that have been done in the past. Frankly speaking, there is nothing really new except for very few things. Most of it is revisiting the past. So I would touch on that statement that I made, but let's talk about what is actually going out. One thing that is definitely going out with uh, published literature building against it is the bridging repair, especially for large defects. This has come in the guidelines, and it looks like that doing a bridging repair, whether it's a bridging onlay or a bridging underlay, which is a laparoscopic repair for large defects, is not acceptable anymore, and reconstruction is the mantra of these days. The other thing which has come under scanner and criticism is the component separation technique, the anterior technique, as advocated by Oscar Ramirez, that is coming under criticism because of the high incidence of wound necrosis, because of raising the subcutaneous flaps. I must say that my personal opinion may differ in this matter. And if we look at the recent systematic reviews comparing HCST and PCSTs, we find that there is probably identical or higher incidence of surgical site occurrences with PCST, possibly because of the increased dissection, but definitely the recurrence rate in posterior component separation is half of anterior component separation because of the larger overlap probably. So there is definitely the posterior component beating the anterior component separation currently. So what is in? We are now talking about hiding the mesh and not trying to putting in the composite mesh inside the abdominal cavity. There is no hard evidence against putting a mesh inside the peritoneal cavity, but it does seem like people are worried about adhesions, about recurrence, about various other complications, the rarer ones like crystallization. So sublay mesh has been revisited, and the Reeves Topa Wants repair is making a comeback after more than 40 years. And these French surgeons who have done great and amazing work in the past, these surgeries are coming back. And people are using them not only in open technique method, but also in minimally invasive method. And things like MyLoss, ETAP, TARM are terminologies that are now there, and all of them represent some form of Reeves Topa repair. So the sublay mesh is becoming the hot favorite, and along with that, the Reeves Topa repair is making a comeback. And plenty of advantages. One of that being we are putting in a cheaper polypropylene mesh. There is no mesh inside the abdominal cavity. There is two layers and so vascularization happening from both ends. So there are plenty of advantages here. The word bridging has been dropped, and more surgeons are now trying to reconstruct the abdominal wall in larger defects, especially. And abdominal wall reconstruction, or AWR, has become a terminology which is not adequately defined, but most people like to mention it, signifying some complex procedure for a complex hernia. Mostly it is about component separation technique, but as I said, it's not adequately defined. But it does stress that we are not talking about improving the functionality of the abdomen and not only putting in a mesh as a separation from the abdominal viscera. So it's not only about protecting the viscera, but also improving the functionality by closing the defect. And the method that has come in the forefront is the posterior component separation, transversus abdominis release, or TAR. And TAR has become very popular in the last 8 years since its publication by Dr. Nowitzki. And this is not only being done by open technique now, but also by endoscopic method and robotic surgery as well. And this is being increasingly employed. Component separation technique may not be enough for very large hernias, and there are some methods that have come in the forefront. I would like to mention two of them which are increasingly being used. One is a preoperative botulinum toxin, and that is being used to paralyze the lateral muscles so as to improve the closure of the defect in the midline, which therefore is called, rightfully so, possibly is chemical component separation. The other technique which is being increasingly used and popularized by the Scotland group, the Dr. Andrew Degoe group, is the peritoneal flap method, and this is increasingly making a noise, and it's giving good results in the hands of people employing this technique, where the hernia sac itself is utilized for closure of the defect, and it's published, and it shows a recurrence rate of less than 3% and satisfactory results in terms of SSO and SSI. Divarication was an unattended problem for long, but a recent group led by one of them being Dr. Wolfgang have published a report on how to classify divarication, what are things to look for, and how to treat them. And that is increasingly becoming important. It's something to be addressed. So now a parabolical hernia with a divarication, the right operation would be something which takes care not only of the hernia but also about the divarication. So, especially if it's a W3 divarication, otherwise there is a high chances of patient dissatisfaction. Amongst the preoperative factors like smoking, diabetes, obesity seems to be the most important preoperative factor in terms of outcome of hernia surgery. And there are publications which have talked about how to manage hernia in the obese, and there are some algorithms. And recently, in 2020, we also published an algorithm of how to manage hernia in patients with obesity. And it's not enough to know what the BMI is, but also to know what kind of obesity are we dealing with, what kind of hernia we are dealing with, so as to devise a right procedure for these patients. In many of these patients, a laparoscopic IPOM seems to be the best thing to do. In some, a bariatric surgery is the right thing to do. And in some, an abdominal wall reconstruction can be done with or without medical weight loss prior to it. So this is what we've been talking about in the INDO-UK-SURGICON hernia session. What is also important is that we have been able to stimulate research in the minds of many hernia surgeons, and nowadays there is a lot of enthusiasm. One of that is also under progress in the form of IAGES mediated or initiative of doing prospective data collaboration on ventral hernia. And similarly, there is so much of research that's going on in this area. There is publication at its maximum in the discipline of hernia. When you see any editor and you ask what are the things that you're getting most nowadays for publication, they talk about hernia. So hernia is definitely the hot topic these days. There's a lot of research, and it's indeed a welcome change, because if you look at the entire meta-analysis, no more than 3,000 patients were involved in finding out what is the right way to manage hernia patients only about a couple of years back, and that has now grown astronomically. So it's a welcome change. There has been a lot of enthusiasm among surgeons who do not wish to wait till the publications come up. And in fact, there has been a lot more exchange of information and knowledge and skill set via social media, whether it's Facebook or YouTube or any other platform or WhatsApp groups. There's been a lot of education which has been disseminating, and much of it is a welcome change in this field, because what is happening is that the progress is now not only 1x but 5x and 10x because of the rapidity of transfer of information. Of course, there's a caveat that much of this could also lead to a hype of a particular procedure or a particular concept, and which is probably not peer reviewed. But that's something that we have to take it in our stride, and something that only time and research and publications is going to sort of steamroll. Hernia has become a specialist practice, therefore, and nowadays there are young surgeons who are aspiring to become a hernia surgeon, an AWR surgeon, and that was something which was unthinkable a few years back. So with that, I think I would wrap up as to what has been going on and what we wanted to represent in the INDO-UK-SURGICON hernia session. I hope that you have liked what we have been able to put up as a show. And if you have any questions, comments, or suggestions, it would be most appreciative, and we would definitely like to incorporate them in our future endeavors and academic programs. Thank you very much. Thank you, Docplexus. Thank you, IAGES, and thank you, Royal College, for this opportunity.
So good evening, everyone. I'm delighted to be the orator for Dr. K Chowbey, who is a very good friend of mine, associated with him from the inception of IAGES. John, thank you very much for a kind introduction, and I'm delighted to see many of my senior mentors, our founder president, Temton Udwadia, Dr. B. Krishna Rao, and many of them on the dais. I first wish to thank Dr. Raman and his team for giving me this opportunity to be the orator for the first orator for Dr. K Chowbey's session. I'm delighted to be here. Dr. Chowbey is a very good friend of mine. He's a pioneer laparoscopic surgeon. I must say, I echo the words of Professor Udwadia, that he is the one who had the vision to establish a dedicated MIS center in 1995 in the Asian subcontinent at the Sir Gangaram Hospital, New Delhi. He was in that hospital from 1984 to 2009. I say that this was a challenging vision of his, because those days, or even now, in corporate hospitals, we all in India are on fee-for-service, and to just move on to a single department was challenging. And he had the courage, vision, and that is what has taken him very high. He qualified from Jabalpur with honors and came to Delhi in 1978. He is presently the chairman at the Max Institute of Minimal Access, Metabolic and Bariatric Surgery, and he's been there from 2009. As mentioned earlier, he has been the past president of this organization, IAGES. He has been the past president of the Obesity Surgery of India and the Asia Pacific Obesity Surgery. He was instrumental in starting the Asia Pacific Hernia Society and the founder president in 2004. He has been conferred honorary membership by the German, Gulf, Indonesian hernia societies. He's been associated with many organizations. He has received countless awards, recognitions across the world. He has received the Dharma Chakra Award, the highest award by His Holiness Dalai Lama. The most recognized of them all is the Padma Shri Award, which was conferred upon him by the President and Government of India in 2002. He has done so many minimal access surgeries that his name is there in the Limca book and the Guinness Book of Records. Over 100 publications and chapters in many textbooks of MIS and hernia, both at national and international levels. He has made large number of presentations, actively participated in national workshops, international workshops, CMEs and conferences. He's happily married, happy man, and all his family are ardent lovers of art. His wife and son are also artists and painters and have conducted multiple art exhibitions. Pradeep and family have a huge collection of art. And in fact, you need to visit his house to see the art exhibition there. These are a few of our pictures. As mentioned earlier, I was the secretary when he was the president of the IAGES. He was instrumental, along with the entire IAGES team, to introduce the guidelines book, and that's a picture of the President of India, and some of the pictures from very beginning till now. Pradeep, congratulations and wish you all the best. I come to my topic. I've added a word conflicts here. And just to mention, when we talk about controversy, what it means is, it means that there is lack of 100% evidence in the methods of treatment. That is when controversies start. I will cover innovations, newer methods, and new technologies. This is just to show the evolution I have seen from the time I qualified as a surgeon in 1976 until 2020, more than 4 decades of controversies, criticisms, and acceptance. The first 10 years was just open surgery. Then we did read about Eric Mohe doing his first laparoscopic cholecystectomy in Germany. And his operation was criticized. They thought that he was harming patients. And basically, they de-recognized him and removed him off the registration and jailed him for some time. And then he was recognized in 1992, which is almost 6 years later, and brought back, given him recognition that time. In 1987, it was Philip Morris' first laparoscopic cholecystectomy, which was recognized, and that became popular across the place. We have our Professor Tempton Udwadia, who did his first laparoscopic cholecystectomy in India. He has been a figure. He has been our guide. He has been instrumental for a lot of things. And as mentioned, he's also been my friend in golf. After him, during 91 and 92, all of us started laparoscopy. Lots of criticisms. Colleagues, doctors, public criticizing on these surgeries and talking about it as circus surgery, crazy publicity stunts and various things. But then this all withstood. Industry came up with new tools, new techniques, and gradually from 92, 93 onwards, the laparoscopy and minimal access surgery spread starting from gynae and general surgery to thoracic, cardiothoracic, cardiac, orthopedic malignancies, and so on and so forth. A small element of newer techniques were introduced, and then came, about 10 years ago, robotics, which is now becoming bigger and bigger. This is the entire evolution what you have in surgery with criticisms, controversies, and acceptance. Just to mention, I go through some important things. I need to mention that laparoscopy is taken off. As far as gallbladder is concerned, today it is considered as a gold standard. Rest of them, appendix is done, but rest of them, The benefits are fully established, but these are in centers of excellence, centers where equipments are available, and centers where you have expertise, and centers where large volumes are done. So when you talk about that, all these procedures which have been mentioned here are accepted. They appear to be, or they are recognized as giving similar results, and they're well done. That this is for centers of expertise. There are a few in terms which were introduced in the middle, like hand-assisted laparoscopy, needle scopic, and natural orifice surgery. But these had their own natural deaths. So they died and they did not progress further. When it comes to trauma, diagnostic laparoscopy has got a big role to play in selected patients with penetrating abdominal trauma. It minimizes unnecessary laparotomies, and therapies can be done with this and reduces the cost. Malignancy is well accepted, as I said, in centers where there is expertise. There is no convincing evidence of port site metastasis or acceleration of disease by the use of laparoscopy. There are enough reports now to suggest that long-term follow-up and survival data supports the acceptance. So results, again, are related to expertise and proper planning of the procedure. Special conditions like pregnancy, previous operations, and liver disease are no more contraindications for performing lap. Extra care and precautions are required. Experience in laparoscopy improves the results. Acute abdomen, accurate diagnosis possible in about 80 to 90%. Helps in planning the surgery, especially approach and incision. Can be used in critical cases for diagnosis in the intensive care department. What is required is individual decision based on hemodynamic stability of the patient. When it comes to inguinal hernia, the results are equal or better with experience, and this applies to centers where equipments are available with expertise. On a general note, 80% of inguinal hernias are still done open. That's because of lack of equipments and expertise in majority of the places. Even in the expert places, open surgery is done in patients who are not suitable for general anesthesia. When it comes to incisional, results of laparoscopy are again similar with good selection and experience. Many places prefer open surgery for large and complex hernias. Abdominal wall reconstructions are useful in large hernias with experience. A word about varus needle and open entry. No clear evidence, even at the end of 30 years, exists between these two. Vascular injuries appear to be more frequent with varus needle or blind entry. And on literature, if you look at the litigations with vascular injuries, but the reports are few on this. With open entry, bowel injuries are recognized, but the advantage you have there is many times it's recognized immediately and corrected, so no untoward problems have been reported. In general, it appears that open is better than closed entries. Optical access is we use in difficult cases and bariatric surgeries, but there are no published literature to support them. Only thing what shows is commercial data. It shows high sales in some areas and some countries. A word about training. We have crossed more than 30 years of laparoscopic surgery, but there is deficiency in the training. We do not have any structured training. All our residents, those who want to learn laparoscopy, learn through some fellowships, programs, workshops, CMEs, conferences, virtual stimulation, and mentoring. Generally, they learn and improve with self-effort. It's found there is a learning curve when new procedures are learned by above methods. Sorry, something went wrong. You can have poor patient outcomes. Sorry, something went wrong. Sorry, something went wrong. You can have poor patient outcomes when these surgeons start practicing the new procedure. What about robotic surgery? As laparoscopy has revolutionized the approach to surgery, robotics and computer-assisted technology are playing a major role in the advancement of surgery. Their role is established because of maneuverability in restricted spaces, complex suturing. They are well established in cardiothoracic, urology, gynecology, bariatric, and other fields. Over here, robotics are here to stay. There will be progress, as we see on costing and equipments. When we talk about conflicts of interest, sorry, again there is some problem. Sorry. Are you able to hear me properly? Yeah. When it comes to controversies, laparoscopy surgery is an instrument-oriented procedure. And when this started, the manufacturers developed the interest. Success in terms of business is always necessary when they have to be answerable to the investors. This brings marketing. So started professional appointments, academic achievements, lucrative consultant contracts, stock ownership and options, and speaker fees. There is solid evidence in social science and research that financial motives many times distort judgment. When it comes to disclosure and conflicts, it's very easy to write, I have no disclosure, but there is no proper definition on what is done. At the end of it, we as doctors need to maintain the trust with patients and public. When these conflicts get exposed by media and press, it spoils our public image. This also has created some disturbance between physician and industry relationship and hindering the progress in the industry. What we need to do is to have a balanced approach. The industry has shown that they have created progress in the last so many years. Cardiac surgery in the form of stents coming in, neurosurgery, orthopedics, and we ourselves know minimal access surgery in the last 30 years has completely changed and revolutionized the approach of surgery. Industry has benefited not only the doctors and surgeons, but also patients, entire society, and the country. What we need to do is to have a balanced approach. Balance between benefits and harms. Results and outcome have to be similar to standard methods. The biggest problem is learning the new methods. It is a big challenge and the greatest drawback in medical field, and more so in the surgical field. With new technologies, new equipments coming in, it becomes a challenge for surgeons to learn the techniques. More so for senior surgeons. When the senior surgeons have to learn the newer techniques and newer equipments like robotic surgery for senior surgeon, it becomes a big challenge. So for us, we don't need to take the challenge. Allow the juniors to develop it and establish. We don't need to get in. But it is a challenge completely different to the physicians. Healthcare is a field where government and country hesitate to spend money on expensive equipment. If these will improve outcomes and benefit society, then we should be able to convince about their requirements. Technology innovations are the key to advances. A few facts about controversy. Many controversies are created. You can prove right or wrong or right, evidence-based. We just heard a debate on closing the linea alba by two experts. Each are able to prove with literature, both are right. And there is enough material on both sides. I just want to say a few things about this necessity of mother invention. Look at this, the virtual conference what we have. I have an opportunity to be one of the few to be delivering an oration on a virtual conference. Never heard of. Made life so easy. You have a calamity coming into the country or the world, and then innovations develop. So there is always an opportunity, even when there are failures. So we have done so well that this conference is so innovative and so well appreciated. I must congratulate here the president of the IAGES, Dr. Raman Goyal, who after taking over faced the COVID situation, and he has really turned the leaf completely by introducing so many CMA programs, so many workshops being done, live shows being done, many people participating, cost effective, and it's a wonderful thing. I think this majority of it is going to stay. We just need to meet for social gatherings. So now coming to two things. There are two types of people who will tell you that you cannot make a difference in the world. One, those who are afraid to try. And the second one is important, those who are afraid that you will succeed. So now coming to this, I must show my appreciation and thanks to these three books, which I read through and gave me an insight into a lot of things, controversies and ethics. One was Michelle Ganner and Moshe, Robert Sage, and an issue of surgical clinics in North America, and plenty of literature to read on top of it. Individually, we are one drop. Pradeep, this applies to you. Together, we are an ocean. You created the team, and the team lifted you up along with you. So you had the ability to create a team. This is the team with him who has grown. So you worked as a team and became big. We all were individuals, and so we did a horse race alone, and whereas you did together and went up. Congratulations.